Today's video will be about trans identity, pathologization and gender-affirming care. But first, let's define some important terms. These definitions are deliberately simplified for the sake of clarity. I will add some details on the screen, so feel free to pause the video to read them. A transgender person's gender identity does not match their assigned gender at birth. I will call transness the fact of being transgender. The term trans identity also exists. The word transsexualism is nowadays deemed offensive. A cisgender person's gender identity does match their assigned gender at birth. A trans woman or trans feminine person is a person who was assigned male at birth but who lives as a woman. A trans man or trans masculine person is a person who was assigned female at birth but who lives as a man. Non-binary is an umbrella term which includes genders that are neither man nor woman. Now that we're all set with the vocabulary, let's clarify a very important point for the rest of the video. Transness is not a mental disorder. As a matter of fact, mental disorders are defined in two main classifications. The Diagnostic and Statistical Manual of Mental Disorders, called DSM, published by the American Psychiatric Association, and the International Classification of Diseases, ICD, published by the World Health Organization. In the DSM, until its fourth revised edition in 2000, transness was included as gender identity disorder and classified under sexual and identity disorders. As for the ICD, until its 10th edition in 1990, transness is included as transsexualism and classified under mental and behavioral disorders. But in fact, there is no reason why transness would be a mental disorder, and this belief is not founded on any scientific evidence, but rather on social opinions of a bygone age. In a 2012 study, Jack Dreschers and Ali note that
from a historical perspective, the classification of gender identity diagnoses as mental disorders was serendipitous. It appeared to have been based more on prevailing social attitudes at the time than ICD-8 and ICD-9 were approved, respectively, in 1965 and 1975, than of available scientific evidence.
in fact, as early as 1993, in the International Conference on Transgender Law and Employment Policy Proceedings, were published the Health Law Standards of Care for Transsexualism. Their principle 1 read as follows.
Transsexualism is an ancient and persistent part of human experience and is not in itself a medical illness or mental disorder.
Moreover, psychiatrization would go a long way towards recognition of transgender people. In Dreschers and Ali's study, we can read,
the relationship between psychiatric diagnosis, stigma and human rights is sharply illustrated by the history of the removal of homosexuality per se from the DSM-2 in 1973, in the aftermath of the APA decision, with psychiatry no longer officially participating in stigmatization, a historically unprecedented social acceptance of gay men and women gradually ensued across much of the world.
Many international stakeholders followed these arguments and put them forward before the publication of the most recent versions of the ICD and the DSM, respectively in 2013 and 2015, hoping that this would allow the removal of transness from the category of mental disorders. The European Parliament took a resolution for the UN Human Rights Council in 2011, stating that it
roundly condemns the fact that homosexuality, bisexuality, and transsexuality are still regarded as mental illnesses by some countries, including within the EU, and calls on states to combat this. Calls in particular for the de-psychiatrization of the transsexual transgender journey.
And that it
calls on the Commission and the World Health Organization to withdraw gender identity disorders from the list of mental and behavioral disorders, and to ensure a non-pathologizing reclassification in the negotiations on the 11th version of the International Classification of Diseases, ICD-11.
In 2017, the Special Rapporteur on the Right of Everyone to the Enjoyment of the Highest Attainable Standard of Physical and Mental Health, yes, this is quite a long title, wrote in his report, also for the UN Human Rights Council, that
it is important to recognize the complex role that a diagnosis of mental disorder plays in people's lives. While many people find diagnostic categories beneficial in allowing them to access services and better understand their mental health, others find them unhelpful, and stigmatizing. Mental health diagnoses have been misused to pathologize identities and other diversities, including tendencies to medicalize human misery. The pathologization of lesbian, gay, bisexual, transgender, and intersex persons reduces their identities to diseases, which compound stigma and discrimination.
Other associations and NGOs called for the end of transpsychiatrization, such as the World Professional Association for Transgender Health in 2010 or Amnesty International in 2017. Fortunately, the World Health Organization and the American Psychiatric Association listened. In the last edition of DSM-5, published in 2013, transness is included as gender dysphoria and included in its own category. We'll dive into the details of diagnostic criteria later, but you can remember that gender dysphoria includes the negative symptoms of transness and must be associated with distress or impairment. As for the ICD-11, published in 2019, transness is included as gender incongruence, categorized under conditions related to sexual health. But you might ask, why not remove translated items from the ICD and the DSM altogether? The answer is quite simple. As we will see in a minute, trans people may need specific medical care, and for this care to be covered by medical insurance or social security, it needs to be categorized as a medical condition of some sort. Drescher's and Ali's article reminds that
Other advocacy groups raise concerns that removal of the adolescent and adult gender identity diagnosis would lead not only to loss of private and public insurance coverage for necessary medical and surgical treatment, but also to the loss of a potent, successful argument in legal cases challenging denial of such coverage to transgender individuals.
now let's see what kind of medical care trans people may need. These types of care are called gender-affirming care. Two main categories are examined in studies: gender-affirming hormone therapy, when trans people take hormones to make their body change, and gender-affirming surgeries, when trans people undergo surgeries to change often characteristics that hormones can change. These two types of care have historically had different conditions to access them. We will see them in a minute. Silly question, but why do trans people seek gender-affirming care? The scientific community has mainly focused on gender dysphoria as the reason for transitioning. That is to say, negative feelings linked to one's gender assigned at birth, such as uneasiness, discomfort, or even disgust. But Florence Ashley, you will see that this name will be cited a lot in this video, and Carolyn Els, in their article in favor of covering ethically important cosmetic surgeries, facial feminization surgery for transgender people, remind us that there are other reasons to seek gender-affirming care, namely gender euphoria and creative transfiguration. It reads as follows.
Gender euphoria is the positive homologue of gender dysphoria. It speaks to a distinct enjoyment of satisfaction caused by the correspondence between the person's gender identity and gendered features associated with a gender other than the one assigned at birth.
Creative transfiguration is a bit harder to grasp.
Creative transfiguration is a related experience that centers on creativity and aspirational aesthetics. Trans embodiment can be irreducibly creative. Creativity is one of the manifold ways in which we may assert ownership over our bodies, transforming them into an art piece that is truly ours out of previously alienating flesh.
These concepts will be useful for us later on. Let's see how easy is the access to gender-affirming care around the world. Unfortunately, I was unable to find a worldwide study on access to gender-affirming care, and I believe such a study does not exist at the moment, which shows the lack of scholar articles around these issues. Nevertheless, I compiled a map using information from Wikipedia and other sources. In red are put countries where either gender-affirming care is illegal, or even just existing as a transgender person. Unfortunately, there is a lot of data missing, so if you're from one of the missing countries, feel free to say what the situation is like in the comments. As you can see, the situation is not so rejoicing. There is still a long way before transgender people are recognized all around the world and are able to access vital gender-affirming care. But I want to focus on countries where access to gender-affirming care exists. How do people in these countries actually get access to gender-affirming care? To answer this question, let me introduce the Bible of transgender care, the standards of care published by World Professional Association for Transgender Health. I'll just call them Standards of Care, or SOC for short. This document has been published since 1979, and its eighth and last version was published in 2022. Since this last version is quite recent, many practitioners still rely on the previous one, so let's focus on it. We'll see the differences between SOC v7 and SOC v8 a bit later. So, you're a practitioner whose patient asks for gender-affirming care. Let's begin with hormone therapy. What do? You open the SOC v7 and read the requirements for hormone therapy, which begin by the following requirement: persistent, well-documented gender dysphoria.
Gender dysphoria. This word is defined in the DSM-5 and it must be well documented. So my patient needs a diagnosis. At least it will prevent them from regretting their decision later on if I make sure they are truly trans.
Maybe you didn't think exactly like this, but that was what most practitioners have thought for the last decade. The diagnostic criteria for gender dysphoria are the following. You can pause the video if you want to read them. Moreover, for surgeries, SOC v7 asks for 1 referral from a mental health professional for top surgeries and 2 for bottom surgeries. But relying on a mental health diagnosis to provide gender-affirming care is really problematic. First, we already saw that transness is not a mental disorder. Then, remember the reasons for transitioning? Apart from dysphoria, there is also gender euphoria and creative transfiguration. In their article, Do Gender Assessments Prevent Regret in Transgender Healthcare? A Narrative Review, Florence Ashley, yes her again, and Ali analyze the DSM-5 requirements and note that
Someone who wants gender-affirming interventions but only experiences gender euphoria or creative transfiguration may be denied a diagnosis because they do not meet the requirement of significant distress or functional impairment.
it also poses a problem for non-binary and gender non-conforming people, since
They are also less likely to meet the threshold for a diagnosis because of the reliance on gender stereotypes in criterion.
what about predicting regret? Ashley and Ali argue that
Each of the criteria for a diagnosis depends on self-report, raising questions about whether they can predict or prevent regret any better than self-reported gender identity or embodiment goals.
Ashley goes even further, explaining that gender assessments and diagnoses are an instance of dehumanizing gatekeeping in her 2019 paper, Gatekeeping Hormone Replacement Therapy for Transgender Patients is Dehumanizing.
We generally trust what other people say about their own mental states. If someone says, "My arm hurts," we typically grant credence to their claim. If someone says that their arm hurts but are laughing at the same time, we may have a good reason to doubt, yet, in the absence of such conflicting indication, it would be illegitimate to doubt them. If I were to doubt that person's claim without serious reasons to believe otherwise, I would be committing an injustice because I would unjustly fail to recognize their authoritative knowledge of their own experience of the world.
Another comparison she makes is with abortions, writing that
We do not typically think that it is ethical to require psychological assessments prior to abortions, for instance, an intervention which bears some parallels to transition-related care. Both are frequently justified by reference to personal autonomy and are frequently but not always motivated by distress, and yet neither pregnancy nor being trans is an illness.
another requirement for metoidoplasty, phalloplasty, and vaginoplasty, which are sex reassignment surgeries or SRS, is 12 continuous months of living in a gender role that is congruent with their gender identity. This requirement is also called real life experience, or RLE, and is highly problematic and deemed unnecessary. In her 2001 paper, SRS without a 1-year RLE, Still No Regrets, Anne A. Lawrence presents some empirical evidence of the absurdity of such a requirement. Indeed, a 1998 study mentioned
10 regretful postoperative patients, 9 of whom were male to female. The duration of preoperative real-life experience ranged from 1 to 5 years and averaged 1.6 years.
showing that orally does not guarantee an absence of regret. On the other hand,
among 232 of Dr. Toby Meltzer's recent male to female patients, 36 patients, so 16%, reported that they underwent surgery after less than 12 months of real-life experience. Their outcomes were no different statistically than in those who had lived full-time in a role for an entire year or longer.
so how to provide care otherwise? Another existing model is that of informed consent. In this model, the only prerequisite to gender-affirming care is consent from the patient, after they were informed of the consequences of the act of care. And actually, if you think of it, this is how most medical acts are done. In the paper Informed Consent in the Medical Care of Transgender and Gender Non-Conforming Patients, Timothy Kavanagh and Ali note that
informed consent is not hormones on demand, which would give no scope to the prescribing clinician's expertise and judgment. Rather, it facilitates the patient's and clinician's collaborative determination of the best available treatment. Clinicians do and should have these kinds of conversations with their patients all the time, and do not generally require the input of a mental health practitioner to help them in this decision-making process.
And if you wonder if it is a recent model, do you remember the 1993 standards that stated that transness is not a mental illness? In the same document, we can read that
Physicians participating in transsexual healthcare shall provide hormonal sex reassignment therapy to patients requesting a change in their sexual appearance, subject only to 1. The physician's reasonable belief that the therapy will not aggravate a patient's health conditions. 2. The patient's compliance with periodic blood chemistry checks to ensure a continued healthy condition. And 3. The patient's signature of an informed consent and waiver of liability form.
as you may guess, the informed consent model suits transgender patients much better. In their 2021 paper, The Informed Consent Model of Care for Accessing Gender-Affirming Hormone Therapy is Associated with High Patient Satisfaction, Cassandra Spanos and Ali showed that among 33 people that started gender-affirming hormone therapy with the informed consent model, 32, it is 97%, were satisfied with the process, and 100% felt actively involved in the decision-making process. You may wonder whether the informed consent model predicts regret as well as the diagnosis gender assessment model. In a 2011 paper named Use of the Informed Consent Model in the Provision of Cross-Sex Hormone Therapy, a Survey of the Practices of Selected Clinics, Madeline B. Deutsch aggregated figures from 12 clinics from the US that used the Informed Consent Model, with a total of 1,944 treated patients. Out of these 1,944 patients, only 17, it is 0.8%, expressed regret, and only 3, it is 0.15%, reversed this transition. And even then, Florence, Ashley, and Ali wonder whether regret is really something to try and prevent. In their previously cited article, Do Gender Assessments Prevent Regret in Transgender Healthcare Narrative Review, they defined retransitions as transitions into one's person gender assigned at birth, and argue that
retransitions are often temporary and reflect a wide diversity of transition trajectories. The process of retransition does not imply that the initial transition was undesirable. While detransition is often presented as an inherently undesirable outcome, many people who detransition express neutral or positive feelings toward their initial transition. Perhaps the person would be displeased with their gendered situation regardless of whether their transition. Perhaps the person would have experienced ever greater regret and distress had they not transitioned. Perhaps transitioning improved the person's lifelong psycho-emotional well-being and life satisfaction despite eventual or transient regret.
the latest version of the WPATH SOC, published in 2022, is actually a bit more permissive to prevent unnecessary gender assessments. The persistent, well-documented gender dysphoria requirement has turned into the two following requirements. Gender incongruence is marked and sustained, and meets diagnostic criteria for gender incongruence prior to gender-affirming hormone treatment in regions where diagnosis is necessary to access healthcare. The referral requirements are also reformulated as such. If written documentation or a letter is required to recommend gender-affirming medical and surgical treatment, only one letter of assessment from a healthcare professional who has competencies in the assessment of transgender and gender-diverse people is needed. Lastly, the real-life experience requirement has been removed. This is still not perfect, but it is still better than Standards of Care version 7. So this part was quite theoretical, but great news, there will be a second part. In that part I'll present some actual examples of trans journeys, showing how access is difficult around the world. I conclude by citing philosopher and gender theorist Paul B. Preciado, who wrote in Transfeminismos, Fricciones y Flujos, "They say representation, we say experimentation. They say identity, we say multitude. They say clinical diagnosis, we say collective empowerment. They say dysphoria, disorder, syndrome, incongruity, deficiency, handicap, we say bodily dissidence." Thanks so much for watching, and stay tuned for the next part. See you soon!